If you're a rocket scientist and you want to understand flow and edema and pressures by studying this equation down here, you can. Otherwise, if you're a human being, take a look at the diagram. Let's review what is such a key concept in pressures and transfers of fluid between various anatomic and theoretical compartments. On the arterial end, we have a high hydrostatic pressure, which manifests itself as forcing fluid out as you get towards the capillary bed. That fluid, which is then out in the intercellular space, gets picked up through thin-walled blood vessels with action forcing the fluid back through the lymphatic system, through lymph nodes, and ultimately into the thoracic duct, and the one on the duct on the other side as well. The fluid also gets picked up by a thin-walled vein through plasma colloid osmotic pressure, kind of like the same reason why Jello tends to suck in water. So these are basically the mechanisms of transfer of water between various compartments. And if you want to think of sodium as mini Jello particles, you could do that as well, because this is the entire principle of edema, and I wanted to go into it in a little bit more detail. Let's talk about the edema of congestive heart failure. Well, there's two really good reasons. One is almost purely anatomical, and the other is physiologic. If you violate Starling's law of the heart, which says the heart will basically pump out any venous return that's given to it. If that law, Frank Starling law, fails, then it can no longer clear the venous blood, and therefore venous pressure, venous hydrostatic pressure builds up. That's the main anatomic explanation for edema. Another, just as logical and precise and complementary, would be decreased renal blood perfusion because of decreased arterial perfusion from the heart, triggering off the renin-angiotensin-aldosterone complex, resulting ultimately in sodium retention. These are the two main classical mechanisms of edema due to congestive heart failure. In the edema of liver failure or hepatic ascites, you can remember that because the liver is really nothing more, when you think about it, between a filter system between portal blood and cable blood. If that filter gets clogged by virtue of fibrosis, we now have portal hypertension or increased hydrostatic pressure in the portal system, and therefore edema in all of the organs which the portal system drains. Another solidly good reason is that the liver is the main, if not sole, producer of albumin, which is the main protein in the jello of colloid osmotic pressure, and therefore a hypoalbuminemia would result in a decreased oncotic pressure, and therefore less flow coming back in from the intercellular space to the vascular compartment, which is edema. So a hepatic edema manifests itself as hydroperitoneum, or if you will, an ascites. And I'm very happy to find that I have my picture here. You'll see this when you go into the clinics and be able to detect through various manipulative techniques that that's really water in there, not fat or air or anything else. There'll be a fluid wave. Another thing to remember is that we talked about hydroperitoneum, hydropericardium, and hydrothorax, or fluid in the three different body cavities, as perhaps due to different mechanisms. But I can tell you from the point of view of an old-time pathologist that if there is significant accumulation of fluid in one of those three compartments, there's a good chance that it's probably in one or both of the other two. Let's talk about renal edema now. There's also two really good reasons to have generalized edema with renal failure, as well as liver failure and heart failure. One of them is that as the kidneys fail, there's sodium retention. And remember we said, as goes the sodium, there goes the fluid. So if the body is retaining sodium, it's also retaining fluid. And also many of the renal diseases, especially the glomerulonephropathies, you have leakage of proteins through the glomerular basement membrane, and therefore you have protein or decreased protein in the blood, not because it's not being made, like with liver failure, but because it's being lost through glomerular leakage. Edema has various adjectives. Edema, which can be felt in the skin and therefore pits after you stick your finger into the skin, is called pitting edema. Dependent edema is almost exclusively referring to edema in lower extremities, which is usually pitting as well. In that case, gravity takes a part in it. Anasarca is the term used for generally total body edema, which of course would probably include effusions in the three cavities as well. We talk about edema in heart failures often left versus right, although it's almost never purely one or the other. In a left-sided edema, the primary place, in a left-sided heart failure, the edema would be primarily pulmonary. In a right heart failure, the edema would be primarily systemic, extremities, liver, internal organs, GI. Periorbital edema is seen in a variety of conditions, and renal is one of the most common conditions you see it in as well. The edema of renal failure often results in periorbital edema. We saw with the edema of hepatic failure results in ascites. Pulmonary edema is pretty much the same as, left congestive heart failure. And of course, in a closed system like the brain, where a tissue cannot expand and have the privilege of being puffy because it's being closed in, the edema of brain or cerebral edema results in a protrusion or herniation or notching of areas in which there are little chances of the brain to escape, like the cerebellar tonsils into the basal cisterns, or the hippocampal uncus over the tentorium between the middle and posterior fossa, or last but not least, especially if it's a unilateral edema, because the falx separates the two hemispheres, if there's one hemisphere that tends to be more edematous, perhaps due to a tumor or a stroke or localizing process, it tends to herniate underneath that falx where there is a little bit of room. Let's talk about pitting edema. Let's do better than talk about it. Let's look at it, because you're going to be pinching those feet every day in your heart failure patients. Let's take a look at the concept of transudate versus exudate. A transudate is a edema which is almost purely water. Therefore, it has a low specific gravity, lower than 1.02 if you want to use a good rule of thumb, and a low protein content, only 3 grams per dl, well below the serum level. An exudate is usually an edema due to damage of the capillary wall rather than just a transudate. Still have a higher specific gravity and a protein content which may approach or even exceed that of protein in normal serum. Let's stop here and we'll deal with the concepts of hyperemia and congestion in our next 10-minute clip, and I thank you very much.